Good afternoon. I think we're going to try to get started. So I'm Priscilla Slanitz. I'm a radiologist up in Boston, and I'm here with Suju Lee, who's from Cincinnati. And we're going to be talking about the tips, troubleshooting, and challenging cases of tomosynthesis and stereotactic biopsy. So thank you very much for spending your afternoon with us. This is our disclosure slide. And our learning objectives today are basically, hopefully by the end of this session, you'll have a much better sense of how to select patients for biopsy on both the prone and upright biopsy systems. And we're going to spend most of our time hopefully giving you some tips on how to troubleshoot some common challenges that you encounter during these types of biopsies. All right, so we are going to use audience response. I've been told, I know we had some issues with the wireless this morning, but if you turn off your wireless and rely on your LTE, apparently this may work a little bit better, but do you currently perform stereotactic biopsy in your practice? We'll just try to get a sense of who's in the audience. If anybody's on the app, you can answer that way too, but we've got some, for those, let's see, So we only have one response, but let's just show by a raise of hands how many people actually are doing these biopsies. So majority of people are here. That's great. Okay. So here's our next question. For those of you who are performing these biopsies, how are you primarily doing it? Are you using the prone table with just 2D capabilities, 2D, 3D, uprights, or doing both prone and upright? Are you at one of those special facilities that has everything? Okay, so we have a mix. Some of us do have those special facilities. No, actually, nobody answered. They have both prone and upright. But I think, we have a mix of both people with some prone and some upright, and I'm sure most of you were not even able to even get into the app, so that's okay. All right, so we've structured this talk with two main parts. There's going to be an overview, and then we're going to spend most of the time talking about some cases. We've put together actually 18 different problems that you might encounter. With every case, you'll see that we pose a question, and we're going to give you probably about 5 or 10 seconds at the most to think about what your answer would be. And there's a few other audience response questions built in as well. So I think the most important thing to know about these biopsies is obviously they're minimally invasive. And we need to know what we're biopsying, why we're doing it, and how to go about it. So we're just going to have a quick, brief overview of sort of some of the basics of the procedure. So what do we actually use this type of procedure for? Well, it's when we're predominantly going to be biopsying calcifications. But we also sometimes will do a stereotactic or a tomosynthesis guided biopsy when we have a mass that we don't see on ultrasound. A one-view asymmetry, so you can biopsy things that you see only on one of the two projections on mammography. And then we're also doing it for architectural distortion. Now, the advantage of the stereotactic or tomosynthesis approach is that it has a similar accuracy to surgery with a false negative rate of only about 1% to 2% based on the literature. And it's a much faster and less painful procedure for patients, a much speedier recovery. And in most cases, a majority of our biopsies are benign, so you're avoiding a surgical biopsy in over 70 to 80% of the patients that you're performing this procedure on. The other nice advantage is that you obviously can confirm the diagnosis of a malignancy and reliably determine the receptor status, which is important as patients particularly might be receiving neoadjuvant chemotherapy prior to definitive surgery. And finally, that preoperative diagnosis, even if they're not receiving chemotherapy, will minimize the number of trips that patient has to make to the operating room in order to undergo definitive surgery. So how does stereotactic biopsy work? Most of you probably already know this, but there is a fixed reference point. You start by taking a scout image, and the point behind that is then now you know your skin entry point, your X and Y coordinates, and then you're taking a pair of images 15 degrees off of midline on each side, and based on how the lesion moves relative to that scout image, you can actually, using basic algebra, calculate where in the breast or how deep in the breast is that lesion. Now, thankfully, these systems are now all automated, but back in my day when I first started doing this, we had to manually do algebra every single time we wanted a sample, and it was rather painful. These biopsies can be done lying down on a table, so in the prone position, or they can be done with the patient sitting upright in a chair, and it's an system that's added onto a standard mammography unit. Now, the upright unit has some advantages. You don't need a dedicated space because it's just added onto the conventional mammography equipment that you already own. It does have advantages for very posterior lesions. Overall, there's really no weight limit except for the weight limit of what your chair can support. But patients do tend to potentially have slightly higher risk of vasovagal reactions, and they potentially are going to move a little bit more if you're doing it with an upright system. The prone table, of course, needs that dedicated space, and many of us have a lot of space constraints these days. It is a little bit tougher to get to some of those posterior lesions, and there are weight limits. So the table actually, just so you know, can support up to 450 pounds, but as long as you're below 300 pounds, you can use the hydraulic lift. So you might occasionally have a patient that's over 300 but under 450, not a great operative candidate. So you can sit on the ground and do this biopsy if you absolutely have to. And the most important thing, I think, with the prone table is you need to have a patient who's able to climb up onto that table and also is comfortable lying on their belly for about 30 to 45 minutes. Tomosynthesis guided breast biopsy is generally going to be used for lesions that you're seeing only on tomosynthesis, or maybe you see them better on tomosynthesis. So that is probably most of your cases of architectural distortion or low attenuation mass. And a recent study did show that tomosynthesis guided biopsies actually have a shortened procedure time as compared to stereotactic, partly because, you know, if you're doing tomosynthesis guidance, you don't take the stereo pair, you just have one tomosynthesis scout and you can get your depth and lesion coordinates just from that one image. And again, you're not also moving between rooms because your post-biopsy mammogram is done in the same room. The devices, most of us these days are now using vacuum-assisted devices, although these procedures can be done with a spring-loaded device. The gauge is somewhere these days between 8 and 12 gauge for the needle size. And, you know, generally we've talked about with these vacuum devices, in order for them to function, the bowl of the vacuum has to be underneath the skin surface. So if you have a very small breast, you may end up having to use an upright add-on system because that system comes with this lateral arm, so you can actually do any breast compression thickness using that lateral arm. But the classic stereotactic biopsy, you usually need, depending on the device, at least 2 centimeters or slightly more in order to be able to safely biopsy. The other thing to keep in mind, the larger your gauge of a biopsy needle, the less likely you're going to upgrade on surgery if you were to do surgery for atypia or DCIS. Now, how do you figure out whether a lesion's even amenable to stereotactic or tomosynthesis biopsy? So I think these are the 3 categories of things that you need to think about: patient factors, lesion factors, and technical considerations. So for the patient, can the patient actually cooperate? You need somebody who's going to be able to either climb up on that table, lie, or sit still for the good 20 to 30 minutes. And can the patient, can the table actually hold? If you have a prone table, can the patient's weight, is it within the weight limits of that table in terms of being able to have the table or the chair hold that patient or support the patient? Can the patient come off anticoagulation? Now, some people have done these biopsies when somebody's on Coumadin. I don't usually recommend that, but I mean, if you look at, there was one study that came out saying that the major complication rate was actually pretty comparable to doing this on or off anticoagulation, but I would worry, obviously, about a large hematoma in that setting. In terms of the lesion, is it really approachable? Is the lesion deep enough that you can adequately bury that bowl in the breast? Or is it too posterior? Is the target a loose grouping of calcification? So one of the challenges we'll talk about subsequently is when you have a loose group on the stereo pair, in order to get the correct depth, you really need to target the same calcification on each of those paired images. And if you don't, your depth may be off. Can we actually see the target? Maybe the target is so faint. Some of the systems do come with 2 spatial resolutions. The prone tables usually have what's called 512 or 1024. Advantage, to using the 1024 is you'll be able to see the fainter target a bit better, but the radiation dose is also much higher. So do we need tomosynthesis, and do you have that capability? And will the breast thickness allow you to use the vacuum device? Or do you need to switch over to a lateral arm? So these are some of the things you need to be thinking about, and we'll talk more about it as we get into the cases. Other procedural considerations. So if somebody's on anticoagulants, ideally you probably want to have them off of it for the biopsy. But as I said earlier, you can do it on Coumadin. You just really are going to be holding pressure for quite some time, and they're very likely going to have a hematoma. Aspirin, we no longer discontinue aspirin. We have them on aspirin all the time, and even non-steroidals I don't even care about. So, I have not seen any difference, but I do worry about Plavix. I mean, I'm less worried about Coumadin, because Coumadin you could give vitamin K and reverse if you really had to rapidly. But Plavix and Eliquis and all these other anticoagulations that are really long-acting, those I do have some issues with myself personally. But you have to, with any biopsy, you're weighing the risks and benefits of doing the biopsy on or off different medications. The potential complications that you'll talk to about patients with, there's bleeding, infection, and even potentially that you may have a non-diagnostic sample. The other thing that I tend to tell patients a lot is that, sometimes there are a few benign diagnoses we get that do require surgery, and we'll go through that list in just a minute. Because patients sometimes, they're told it's benign, but then they're told they have to have surgery, and they're like, why would I have surgery? It's benign, it's not cancer. So I do think sometimes preparing the patient up front actually helps them to have a slightly better experience if that does happen to them. And then post-procedure, you want to remind the patient not to go and run a marathon or train for their marathon with, wait 24 hours, let things kind of heal up a little bit, to use the ice and the Tylenol and not to shower or expose the area to any bodies of water until things have healed pretty well. So this was our next audience response. So biopsy of a left grouped calcifications revealed columnar cell change with calcifications in LCIS pleomorphic variant. What's your next step? Are you going to let the primary care decide, defer to the breast surgeon, issue an addendum regarding concordance or discordance, or recommend routine screening? And hopefully some people have been thinking about this. We got 0 responses, that's okay. But how many people think they should let the primary care decide? Good, okay. How about deferring to the breast surgeon and let them decide? Okay, how about issuing that addendum for concordance and discordance? Okay, and how about recommending just routine screening? So interesting, we have a split. I think the 2 in the middle were the popular ones. I would argue, just like John Lewin said, that the correct answer is what Suju and I have decided, which is actually answer C, issue an addendum with concordance, discordance, because you're going to, in that addendum, actually make a management recommendation. And I think you want to be a more active player in the patient's care and be part of that multidisciplinary team and not just let the breast surgeon tell you what they're going to do. The other thing about pleomorphic LCIS is it is actually treated as though it's DCIS. So the pleomorphic variant of LCIS is not like typical LCIS. So it is one of those diagnoses that we do actually recommend surgical excision for. So the important thing here is just rad path correlation. You need to assess concordance. You need to communicate that to at least the referring physician and sometimes directly to the patient. We have a nurse navigator where I am, and she actually is talking to patients with their biopsy results and referring them appropriately, if need be, to our breast surgeons. And you're going to recommend surgical excision, and we tried to simplify this a little bit because there's probably a few things on that list that people go, well, we don't always do that. But any malignancy clearly needs to be excised. Pretty much any atypia, unless the atypia is thought to be incidental, and that's a whole other category. Most radial scars and complex sclerosing lesions are being still surgically excised. Most fibroepithelial tumors are being excised for the concern that they might be a phylloides. And of course, a discordant lesion generally will be rebiopsied or surgically excised. All right, so we're going to move on to those cases. And Suju is going to take over from here for a little bit. So here we go, our first case.
The first challenge is for you to find me behind the podium. So here, we like to go over some real-life challenges of biopsy on the supine and upright position. So here, our first challenge, 48-year-old with grouped calcification in the far posterior and the outer right breast. How are we going to successfully sample this lesion? I'm giving you a few minutes to engage your brain. Don't fall asleep. So here is the calcifications, way outer, way upper, way posterior. The challenge is to how to bring this target into the biopsy window. First, you can try a lateral approach. By using the lateral approach, you allow the natural mobility of the breast to bring more posterior tissue. As you can see, where is the, I'm looking for my arrow here. You can see that you gain that much more posterior tissue.
Dig the arrow on there.
Yeah, I got it, yeah.
I think it just shows.
Yeah. So compared to the cranial-caudal projection, that you get more breast tissue posteriorly. If that fails, you can try the next method, which is called, it's not advancing. Maybe next.
Okay, hold on for a second. Let's go to next.
We have to get that off.
I know, why is it doing that?
Get rid of that screen, then we
Can
can.
I scroll up here?
Oops, sorry.
Okay, maybe it will advance now.
Yeah. It
There you
will
go.
now.
Okay, perfect.
So when the lateral approach, a simple lateral approach doesn't help you, arm through the whole method. That here you place the breast, shoulder, and the arm through the opening of the biopsy table. And again, it allows you to pull more posterior breast tissue and more axillary tissue into your field of biopsy.
How many people have done arm through the hole? Just out of curiosity.
Okay, so it's not really an unknown trick. So here is a posterior. So here is a 2D. This is a scout using the lateral approach and cannot see your target. Of course, you need to zoom in, check your landmark, make sure you are in the right area, make sure you are posterior enough, and also make sure that that reference bar does not obscure your target. When that fails, here is an example of, we go to the arm through the hole and we successfully pull our target into the biopsy window. When does the arm through the hole fail? When you have a patient with a very large breast and a very broad shoulder, and you cannot fit both structures through the hole of the table opening. And we have a patient like that here, okay? So here is that posterior lateral tissue that we cannot use the other method. In this situation, your probably only option is to biopsy this with the upright unit. So here is the patient on the prone table, cannot find the target. Here is the upright unit. It's usually allow you to position for more posterior tissue and also give you a little wider field of view. And here it shows that the target is successfully biopsied with the upright unit. So next problem, 52-year-old with faint calcifications in the right breast. How are we going to sample this? Okay, so you can barely see your target. You are really squinting your eyes and are not sure, how am I going to target this? One suggestion is to increase your technique. Increase KVP or MAS or both. And sometimes it allows you, it usually improves the visibility of your target. Another method is black-white inversion. To your right, you can see the microcalcifications better as black dots on a gray background as opposed to white dots on white background. So that might help you. Or you can try to tighten the breast compression. The opening of the compression pedal actually causes a lack of compression in your area of interest, and it can compromise the visibility of your target. And the solution is to stretch a tegaderm over that opening after the skin is cleansed. And that causes much better compression of tissue. Here you no longer see the bulging, and you can then perform hopefully that improves the visibility of the lesion, and you can biopsy through the tegaderm. Other solutions that we didn't talk about yet, using filter, sharpening, adjust window and a level. If 512 mode, increased technique doesn't work, try 1024 by 1024 mode. Or you can increase image contrast by lowering the KVP, or we talked about tighten compression. And then the last, do not be afraid to set manual technique. Use the same technique you use for your diagnostic imaging. That's yours.
Oh, okay, I'm problem 3. Okay, so I love loosely grouped calcifications. Particularly when you've got, sometimes you'll get referred in a case where there's almost like regional calcifications, but there are, and so the challenge with this, you need to figure out how you're going to target these, because as I said earlier, on the stereo pair, if you choose different calcifications on each of those images, you're going to end up with your depth being off. So how can you overcome this? And there's actually a very simple way to do this, at least this is what I do. Maybe other people in the audience have even better better suggestions. But I actually, in these cases, do multiple targets. And what I'm looking for is to make sure, particularly that my Z is very comparable on multiple targets, so then I have a good sense of where I am in space. The X and Y can be, pretty close and off a little bit because I'm in different spots on the X and Y coordinates, but it's more I'm looking to make sure all of my Z depth lines up, and therefore I know no matter where I go in, whatever target I choose, I pretty much know I've probably chosen the same calcifications on those two pairs. And I think it's a really good trick that at least I found being very, very useful and to help me succeed on some of these very loose groupings that get referred in. Okay, I think you're up again, Suju. 48-year-old with grouped calcifications, but you've got a very thin breast, only 2 centimeters thick. Think about how you're going to deal with that thin breast.
And I think we actually have an audience response question. 48-year-old breast 2 centimeter thin. Would you A, recommend localization, B, recommend 6 months follow-up, C, attempt with petit needles, D, attempt stereo biopsy with lateral arm? Oh. Well, I know it's not very user-friendly system.
Who wants to do wire localization? Very thin breast counts. Okay, how about follow-up imaging? How about the petite needle? Few for petite, okay. How about the lateral arm?
Yeah,
Okay.
so C and D are pretty evenly split. I think the petit needle is an appropriate answer, but sometimes 2 centimeter is pretty challenging, even with petit needle. And the D, the lateral arm approach, it definitely will get you the tissue. But they can both be, Why do we have this?
I don't know. Try going down again.
Okay.
Oh, well, I don't know.
Well, we got an extra. Oh, my negative stroke margin picture didn't show up. Okay, that's all right.
It's okay.
It just shows a thin breast with a needle piercing through the back end of the breast and then striking the image receptor. And that's what we call the negative stroke margin. I had a nice picture, sorry, but I hope the rest of the pictures work.
I hope so too.
We checked, yeah. So there are many possible solutions for the thin breast. One, you can try the petit needle, as we say, here it worked. Okay, so the petit needle has a shorter sample notch and a shorter dead space compared to the standard needle. So hopefully that reduces the length of the needle so you avoid exiting the breast and hitting the image receptor. Some company even make it with blunt tip and can even do biopsy down to 2 centimeter thickness. Okay, other approaches try to change needle approach. Of course, we usually select our best approach to start with, but sometimes when that doesn't work, by switching to the orthogonal plane, it may change the location of the target enough to allow safe insertion of the needle. Just think, outside of the. Well, if your negative stroke margin is only minimally negative, you can consider inject local anesthetic agent distal to the lesion to increase the depth of the tissue slightly. Or you can pull the needle back before you fire it within the breast. Or better yet, you can fire the needle outside of the breast, then manually place the needle into the breast. Either of these methods place the target in the distal end of the cutting chamber while still allow adequate sampling. And here you can see the needle doesn't hit the backside of the breast. Another method is called bolstering. And the bolstering is to apply opposing pressure opposite of the compression direction from the nipple up. It's the same concept as push-up bras. So you can accomplish it either with a stack of 4x4 and a surgical tape, or you can use IV bag, suspended, or you can use ace bandage. And that increases the breast thickness to allow you the biopsy. Okay, or you can use this air gap technique. Here, it's double paddling. You apply a paddle between the breast and the image receptor, or you can use a plastic jar. And here you can see the bulging tissue. The tissue bulge into the airspace when the needle is being manually placed. And so that allows you to place the needle at your target. If the needle should exit the breast, they exit into the airspace. All you get is a pierced skin, but there's no damage to the receptor. It's just a hole, okay?
I would say you probably should tell the patient if there's a chance that might happen, so they're prepared.
Yeah. So the last but not the least is the lateral arm approach that we talked about earlier. And so instead of approaching biopsy, through the biopsy opening, you swing the machine laterally, and you can approach the breast from this direction where there is adequate thickness of tissue. But of course, you have to have the equipment, available to you. How about breasts that are too small to cover the entire opening of the biopsy window? The airspace that's not covered will cause degradation of images. And the way to overcome this is to use Play-Doh, and you can contour that to the shape of the breast and tape it on the image receptor. Or you can just take an aluminum foil wrapped around the compression pedal to shield that airspace. Here is an example. Here, without the shield, with the airspace, the tissue is usually under-penetrated, and you cannot even see your target. With shielding, miraculously, the image is improved, and you can see your target well. Question 5. Okay, 48-year-old with grouped calcifications that are only 0.8 centimeter deep to the skin. How are you going to biopsy this? Thinking about it? Okay. So a superficial lesion is a challenge because it causes the aperture of the sample notch to be exposed outside of the breast. And this has to be covered, otherwise the skin will be traumatized during the biopsy. One of the methods is to use a skin hook to pull this skin over to cover the aperture, or you can inject the extra lidocaine deep to the skin and also in the skin to raise a big skin wheel to cover it. Or if you are lucky to have a variable aperture sleeve available to your device, you can advance that sleeve to cover that aperture. In this case, you just tell the technologist, give me half sample or give me 3/4 sample, and it will adjust. Or if you don't have that, you can still do the biopsy. You can push the needle deeper to be completely into the breast, and that place the target into the backside of the cutting chamber. But I usually, if I am not sure that my needle is deep enough, I listen very carefully on that first biopsy to hear. If I hear a hissy air leak sound, I stop. Adjust the needle some more. Okay. Next question, next problem is we have a 48-year-old with grouped subareolar calcifications. How can you biopsy this? We used to, in our center, we used to get referral from outside institutions, say, subareolar calcification, can biopsy it, send to surgeon, and then we would ask to do the biopsy. So it is a challenge because it's difficult to visualize the lesion in that area, difficult to anesthetize adequately. The compression, the breast is very thin on compression, and it's prone to hematoma formation. And the way to overcome it is a roll the nipple technique. Anybody use this? Okay, so, sorry. So here you place a BB on the nipple. Then you roll the nipple to tuck under the breast while the breast is being compressed. Now you can see your target separate from the nipple, which is marked with the BB. You also have increased the thickness of the breast. And if you want, then you can biopsy it with a petit needle to minimize hematoma. Okay, next problem. 48-year-old with calcifications, but you can only see it on one of your stereo pair. How are you going to biopsy this? So here, your target plus 15 degree, minus 15 degree image, your target is at the edge. Sometimes, a lot of time, it actually is completely outside of the image and you can see it. So you can either reposition the breast so that the target is better positioned, or you can go ahead and biopsy it by target on the scalp, okay? So here, you swap the minus 15 degree image with a straight-on scalp. And then you can proceed and put the needle in target and put the needle in using these two images. And this is a pre-fire image. This is post-fire. Okay, so post-fire, you can see that your target is superior and inferior to the needle at 12 o'clock, 6 o'clock position, and it's to the left. So it's 3 o'clock, so you can sample your target 12, 3, 6 o'clock, and here you get a very successful biopsy with lots of calcifications. Let's see.
Okay. Moving on to problem 8. Let me just get, okay, so we have a 63-year-old. There are some suspicious grouped calcifications, and we have a large vessel lying right over where our calcifications are. So I know they're hard to see, but this is our target of calcifications, and there's this gigantic vessel here. And the real question is how are we going to go ahead and biopsy this? I mean, how many of you would just go straight ahead? Go ahead, let's keep going. So some people might want to just pass right through that vessel, but I guess the first question is where is that vessel? That's what you should be asking. Is that vessel actually in your path? Or is that vessel actually on the far end and you're not actually even going to get anywhere close to it? So in order to figure that out, you would actually have to get a stereo pair, and then you can actually target not just your lesion that you're going to be biopsying, but you can actually target on the vessel, and based on that, you can see in this particular case, you can see the X and Y were actually pretty close. The depth tells you that this is superficial to our target. So if we were to go ahead and not reposition this patient, you're definitely going to go right through that vessel and potentially, have a large hematoma or a lot of bleeding related to that. So usually what you can do is you can ask the technologist to roll the breast tissue one direction or the other, repeat your scout, and more than often you'll be able to roll that vessel away from your entry point and successfully biopsy without having any major complication. Problem 9, a 48-year-old with suspicious grouped calcifications, and when you do your pre-fire imaging, the target is off. Now, why would that happen, or how you're going to now be successful at biopsying this? Well, you have a couple options. I guess it depends on how far off you are, but generally when you're giving local anesthesia, it depends on how much volume put in there, but we're all variable. I only usually put maybe 1 or 2 cc's total until I'm really, sure that we've gotten into our good position. But some people put a lot of numbing in up front, and that can displace the target. And the other thing that happens as we advance this needle is often, I'd say, the tissue displaces things because you're fighting with the dense fibrous tissue and the Cooper's ligaments. So what you can do for this is actually, before you actually deploy your device, retarget. And, so I usually do it this way because I retarget, and now I have a new target, and I can move my stage to that location and then deploy the device. And then you're almost certainly going to be right on target. I have seen other people bring up the little ruler on the toolbar, and they're measuring from the reference point how far to the left or right they are, and they adjust their X and Y that way. But I think this is probably more accurate. Just retarget. It will be rare that you're so far off that you'd actually have to re-enter, unless the patient really moves. Problem 10, a 48-year-old has suspicious calcifications, and the needle actually falls short of your target. So you went in the right distance, you've deployed it, and you should be there, but you're nowhere near the target. You can see that it's definitely past the tip of your needle. and why would that happen, and how are you going to sort of deal with it? So it happens sometimes that, surgeons will tell you that breast tissue is so variable in the OR. Some people have such dense tissue that the surgeon will tell you they go through 12 different scalpels just to cut out a piece of tissue. So some people's tissue is like a rock in there, and it just fights you every bit of the way. So you get what's called the snowplow effect, and you really have to be patient with this. You can try to retarget and advance and push the needle in further to get to the new depth, but I found that sometimes in that very dense tissue, you actually advance and then you're gonna recock and redeploy, and you may have to do that several times to make progress to sort of tunnel through that dense tissue. The other thing I've rarely had to do is actually take some biopsies way before I'm really biopsying the lesion, but just to clear my path and maybe break up some of that dense tissue or break up the Cooper's ligaments that are fighting against me. And generally, if you're patient and you do some of those maneuvers, you're going to be successful and eventually get to the correct depth. How about this problem? A 48-year-old post-biopsy, and her biopsy clip is at least 2 centimeters away from where you sampled. Or even worse, maybe your clip is not even present. What do you do at that point? I mean, I can't imagine this happens to any of you guys, but those biopsy clips are perfect, aren't they? They clip right where you took the sample. No, don't you wish? So why does this happen? I mean, particularly when you have a clip and it's off by a lot, it's usually the accordion effect. So as they come out of compression, for whatever reason, the clip kind of migrates down the tract that you've created for the biopsy, and it can land sometimes quite far off. I mean, I've had procedures where it was a lateral target and my biopsy clip's way in the medial breast, and I'm like, that's interesting. Not going to be very helpful. But there are different things you can do. But a recent study came out, and actually, we should not all feel too bad, because anywhere between 13 to 27% of the time, your clip is going to be off by over a centimeter. And you have several different options. So I'm from the era where we never even had biopsy clips, so I can localize anything by landmarks, which you certainly can do, but I mean, some people's breasts don't have a lot of landmarks. So most of the time, I would say we want to try to make an attempt at placing another marker, at least to have some kind of landmark or reference point in case that patient needs to have surgery. So how are you going to do that, and when are you going to do it? I would advise you probably to do it at that visit rather than send them home and have them come back. And so this was a case where you can see there were some calcifications. They got biopsied, and on the post-biopsy image on the far left, you can see that, how did that go up there? That there is a clip on the final stereo image, but on your post-procedure mammogram, there isn't. Now, this happens usually because they maybe were bleeding, so the clip is now bled out with the hematoma and everything. And so how can you handle this? Now, if there was still, sometimes you'll take this image and there's no clip, and the clip didn't deploy for some reason. Okay, that's easy because you're still in the breast. You can just put in a different clip and you're done. But in this case, we've got them off the stereo table. So you could put them back on the stereo table and restart, but I don't think that's as necessary. I think most of us would take them to ultrasound, find the hematoma, which is where, the hematoma is going to be centered over where you took the tissue, and put the clip in under ultrasound. And then you can repeat the mammogram, and in this case, you can see how very clearly the clip is now close enough to where the original target was. Problem 12, 48-year-old, had a biopsy, and the specimen radiograph doesn't show any calcifications. I always love these. You're just like, really? It was perfectly targeted. Where are those calcifications? I doubt this happens to any of you guys either. Unfortunately, I've had this happen to me multiple times, and I've come up with some good creative solutions. So the nice thing, the old systems never had this radiolucent cannula, but one of the things I will do in this scenario is I'll pull back the device, leave my radiolucent cannula in there, and take a stereo pair and see if I can see any calcifications. Amazingly, sometimes you'll still see them there, and you're like, okay, now you can retarget, and you can reposition it and go again and hopefully be successful. So that's something that, definitely has worked pretty well. Now, of course, there are times where there are no calcifications left, and you're like, well, wait a second, there's no calc in her that I can see. There's no calcs in my tissue, so what happened? Bottom line is milk of calcium, which we're not supposed to biopsy, but once in a while we do have to biopsy it because it doesn't behave classically on imaging. You want to alert the pathologist that this could be milk of calcium, because milk of calcium, once it's out of the breast and is now redissolved in, most of these vacuum devices have saline flushing through, so it gets redissolved in the fluid, it's no longer going to be radiographically visible. And so, but they can go and look for the calcium oxalate crystals on histopathology. The other thing I do often in these cases when I don't have the calcifications, but I don't see them in the patient, I still will do a magnified CC and lateral image after the biopsy to see if I see anything residual in that breast. So those are different things that you want to try. Now, problem 13, a 48-year-old had a biopsy, specimen radiograph shows calcifications, so we felt good, we did a really good job, but now the pathologist tells you, sorry guys, I don't see any calcs. So what do you do about that? There are no calcifications that they're reporting. So you think you got the target, you're pretty sure, you got a specimen radiograph, it looks great, but you don't have anything on pathology to account for what you apparently removed. And this never happens to any of you guys either, I'm sure, but unfortunately it's happened to me a few times. And so one of the things to think about is that you can actually image the, one thing you could do up front is put your specimen's calcifications and no calcifications, and that helps your pathologist sometimes up front when they're processing. But you can actually image the actual specimen blocks, and then once you can identify the calcifications that's in the specimen block, they can take special slices through that area and hopefully then identify some calcifications. So that's one option, to do the radiograph of those tissue blocks, and that can then help them localize. Because the reality is your pathologists hardly look at any of the total amount of the tissue. They're just taking representative samples of tissue that they're making into slides. So there's a lot of other tissue that they have not actually even examined. So usually it means it's probably in the tissue block. They just need some help finding them. The other thing, if you think it might have been milk of calcium, tell them, okay, do the polarized light to look for those calcium oxalate crystals. All right, a 48-year-old with a low attenuation mass or asymmetry now presenting for biopsy. How on earth do you know you've gotten this? So most of the time when you're doing calcifications, you do the specimen radiograph, you see calcifications, you feel great, you put your clip in and you're done. But when it's a low attenuation asymmetry or low attenuation mass, it can be actually quite challenging sometimes to know that you've actually gotten the target. So how are you going to confirm that you did? Well, you can certainly wait for your pathology and then do your radiology pathology correlation and see how you did. So this was a case where there was a non-calcified mass that I circled in the yellow there. And so they wanted to pursue this, and they did the biopsy and they put a clip in, and the biopsy came back fibrocystic change. And the radiologist who did this procedure was a little concerned because they really didn't think it was cystic change. It was a new mass that had developed. It looked a little irregular, but maybe it was some kind of fibrocystic change. So they ended up doing a 6-month follow-up. And in this case, you can now see that the biopsy clip, after all the biopsy changes went away, is removed from the actual mass, and the mass had actually gotten a little bit bigger. So this then had a repeat biopsy and turned out to be invasive ductal cancer. And I think what you can learn from this is that there's a couple things you can try to do to help guarantee that you've biopsied the correct spot. One, if you've got a lesion that is in a dense lesion surrounded by fat, you could do a specimen radiograph to see if you can see some of that dense lesion in your specimens. I think one of the things in this particular case, the marker they had put in was embedded in a polymer core. And so probably avoid just using just a pure marker rather than something that's embedded in another material that could obscure your target was probably not as advisable to use in this situation. And of course, always do the radiology pathology correlation. Now, we're not recommending to do short interval follow-up for every benign biopsy, but these might be rare cases where you might consider doing follow-up if you have any question that you may or may not have adequately sampled the lesion. And this is just an example of how the specimen radiograph can be useful sometimes because you can then confirm that you have some dense tissue within this excised samples. All right, and now we're going to finish up with some 3D guided information. Our last audience response question is, compared to prone biopsies, the stereotactic biopsy using an upright unit typically has a longer procedure time associated with increased risk of vasovagal, can only be performed using tomosynthesis guidance, or is less prone to lesion movement after positioning. And we'll see, nobody's probably answered. Okay, so how many are going for typically has a longer procedure time? Nobody likes that one, okay. How about associated with an increased risk of vasovagal reaction? That seems to be a popular answer. If you didn't raise your hand, you might want to raise. No, I'm just kidding. All right, how about can only be performed with tomosynthesis guidance? Okay, and how about is the less prone to lesion movement after positioning? Okay, we got a smart group here, Suju. They're all guided. Clearly, risk of vasovagal reaction is the correct answer on this one.
Okay, great. So here we are going to, these are some tips I learned by mistake sometimes of doing tomo-guided upright biopsy. To your left is an 8-on upright biopsy unit mounted on a mammogram equipment. In the middle, as you can see, the current available equipment, this needle comes in at a slanted angle towards the breast. So when you numb the tissue, it's good to numb along the expected trajectory of the needle instead of numbing vertically up and down. You numb along that track. Also, when you put a skin nick, instead of center your nick right at the needle tip, you might want to bear it ever so very slightly away from the needle tip. And that would actually allow more smooth insertion of the needle. So here is an example where we have a small focal asymmetry undergoing tomo-guided biopsy in superior approach in craniocaudal direction. And a note that the slice location is number 22. So we suggest that you target on the nipple side. That's the nipple. You target on the nipple side, which is 6 o'clock on this equipment. Once you set on the target, the console will show you an instant guidance screen that gives you exact XYZ number, but I found it also very helpful. It gives you a cross-sectional image to tell you your distance from skin to the sample notch, from needle tip to the image receptor, and also the relationship of your target to the sample notch. So at this point, you can adjust the needle depth to adjust the Z in the G direction. If you have a deep lesion and the machine tells you that you have a negative stroke margin, you can pull the needle back. We call it jog up. You can pull the needle back and to increase your distance to the image receptor, and you put your target in the distal end of the cutting chamber. Or if you have a superficial lesion and the equipment tells you that you don't have enough space here, enough distance, you can bury the needle deeper. We call it jog down using that button. And then you can increase the distance to the skin and perform the biopsy by putting the target on the back end of the cutting chamber. We talked about that. Okay, so when your needle is in the right position, the equipment will tell you, it will give you all green in XYZ direction, and the difference in number is 0. So now it tells you your needle is in the right position, ready to go. So you wanted to check needle position pre-fire, and I like to use, you can use a single tomo image to check your needle position. A quick way is to go straight to that slice 22 where your lesion is, and then your needle tip is going to be there. But your target may not be. Your target may be snowplowed, it may be pushed around, so make sure your target is within a few slices of your needle tip. Okay. Or some of us are more comfortable checking pre-fire position with stereo pair, and here it is. You can do it. Post-fire, if you want to check needle position, you have to use stereo pair because the needle would otherwise be obscuring the target, and the target won't be visible with a tomo images. Here it looks perfect. Some experienced operators are actually very comfortable operating on pre-fire image alone. They see the needle in that position, they say, okay, I'm ready to fire and go, and they save time by omitting the post-fire image. I'm still not that comfortable. I always check. Okay, so if after firing the needle, you notice that your target is off slightly from the needle, you can adjust the needle position within the breast, use the jog mode. So you can jog along the X direction or the Y direction to put the needle closer to your target, and each push of the button adjusted by 0.5 millimeter increment. So problem, 38-year-old undergoing tomo-guided biopsy for architectural distortion in an upright unit. She's feeling faint. What are we going to do with this? How can we prevent this? So this most likely is due to vasovagal reaction, and it's more common with the upright unit. The key is to distract the patient and also limit their visualization of the biopsy equipment. And the easy way to do this is to put another support personnel by the patient and engage with them, little chat, conversations, keep their head away from the biopsy device, how's grandkids, what's your hobby, so on and so forth. Keep the patient cool, and if patient has a track record of vasovagal reaction, you wanted to biopsy them in decubitus position. And this is an example of how you can, even with an upright unit, you can place the patient in decube position. And here it shows approach the right breast biopsy with a lateral approach. Okay, so problem 16, 38-year-old with lesion closest to the inferior aspect of the breast. How can you biopsy inferior lesion on an upright unit? So here we have a 38-year-old on baseline mammogram. I'm sorry, did I? Yeah. So she had 2 adjacent lesions in the inferior breast. On CC view, the more medial lesion looks like a fibroadenoma. We say, we are going to watch that. But the more lateral one has microlobulated margins, and when we ultrasound, we aren't sure this is the correlate for the mammographic lesion, so we decided to biopsy this lesion using the tomo. The problem is the 2 lesions perfectly superimposed on each other in a medial lateral view. What luck. So it's really neither medial nor lateral approach is going to be accurate, targeting the one you want. If you do superior approach, there's really not enough stroke margin to allow you to do superior approach. So we are stuck with an inferior approach. So this is how you can do it. You place the patient in decubitus position, you swing the machine around, put the biopsy opening on the inferior aspect of the breast, and you can do this biopsy. Okay, next problem, 68-year-old will have trouble sitting still during the biopsy. That happens, right? Patients, Parkinson's, or hopefully not, but just unsteady. How can we biopsy it in the upright unit? Okay, for unsteady patient, you need to provide support pillow on their back, and you should, instead of, we advise targeting the lesion on the nipple side. Instead of doing that, you should consider targeting it on the chest wall side. And this is how it looks. So here's your classifications. The needle is on the chest wall side. So if the patient slide back on the chair, the target is going to slide into the needle instead of away from the needle. So that's the reason we recommend this approach for unsteady patient. Just remember to turn your needle notch to 6 o'clock so you can still visualize your target adequately. Okay, problem 18, 68-year-old with lesions that moved between scalp and the insertion of pre-fire needle. It moved. So what are we going to do with that? Here is that example. So a patient with calcification in the inferior breast. Okay, so we selected a lateral approach. Generally, we like lateral over superior just because it's less visible to the patient. So we use the tomo guidance, but after we insert the needle, we noticed the target dropped away from the needle. It migrated inferiorly. We actually look at the skin mark here at the top of that window, and it looks pretty good. So we just pull the needle back. We pull the needle back and do a repeat scout, and then this is when we realize the breast droops down. Okay, it has drooped. So we kind of take the breast out of compression, dry it, and reposition, retarget. This time we reposition it in a drooping position, and that's important, and it helps us get the biopsy done. So why? On an upright position, medial or lateral approach is very vulnerable to lesion movement in the vertical location, especially if the breast is large and heavy. Okay, so, and it's further aggravated if the breast is wet. They have transient vasovagal, they are sweaty, nervous, whatnot. So to avoid it, you should dry the breast surface before you position the breast. You should mark the skin edge still so you can readily recognize when the breast has dropped. You should place the breast in a drooping position to start with, because that's the most stable position. Or, when all else fails, you can biopsy it using superior or inferior approach.
Okay, we're just going to quickly go through a few teaching points to summarize everything and then open it up for some questions. So on the prone, you want to target directly on or slightly inferior to your lesion. And if the calcifications, if you have a very faint target, limit the amount of local anesthesia that you give up front. I didn't mention that before, but that's important. Honestly, in my experience, most patients do very well with a very good skin wheel, and they don't really need that much deep numbing, particularly in the beginning of the procedure. And the devices we're using now often are giving the anesthesia while we're actually doing the biopsies. Use multiple targets if there are loosely grouped calcifications. You can target on scout if the lesion's only seen on one pair, or use tomosynthesis to guide. You can retarget on your pre-deployment or pre-fire if your targeting is off on that image, and it's important to do that so that you're on target when you're in the post-deployment mode. And then, definitely perform specimen radiography to confirm that you've gotten your target. Tips for the upright, most important thing I've found is distract the patient. Keep them occupied talking about whatever they so desire. Believe me, I've learned a lot about tattoos recently, just very unusual topics that come up in conversation, people's families and all the troubles they're having. Whatever they want to talk about, you're going to show interest that they're distracted. Keep the room and the patient cool. So you don't want to have a 78-degree room where they're, you really want to keep them on the cool side. Allow the breast to droop, particularly if you're doing a lateral or medial approach, and then target on the chest wall side in case the patient does move back or pull out of the machine. And then for both of them, you can always image through that radiolucent introducer if your specimen radiograph does not seem to have the lesion. And you want to place a biopsy marker, and generally most of us know this, but we're using different shapes for multiple sites. And you want to note the location of that biopsy marker on the post-procedure mammogram in your addendum so that if the patient does end up needing further intervention like a localization, your colleague who inherits that case has a much better chance of knowing whether or not the target is the clip or the target is a couple centimeters away. And of course, check for your radiologic pathologic concordance. So we'd like to acknowledge two other radiologists that are not up here at the podium, but did help contribute a lot of the schematics and some of the cases, Mary Mahoney and Rifat Wahab, as they really were invaluable contributors to this presentation. And thank you very much for your attention.